very much, Dr. Kishuri, for coming to this discussion. We are glad we can have insights from you about the role of the clinician, researcher, and educator, which you really exemplify. Thank you.
In terms of sequencing, the first one was really the clinician. I started out as a medical student, and as a medical student and young doctor, in the public hospitals, I began to realize that hospitals were so run down, the patients used to get so desperate, and that kind of setting also demoralizes good staff. So early on, I actually set out to be a good clinician, and I wanted to see what difference I can make to that situation. And my thoughts then were that if I could do my job very well and influence somebody else to work the same way, then we have two of us doing things better. And if we each in turn influenced other people, then you can have a growing number of people who really want to provide a good service for patients. Then slowly over time, especially after I finished my postgraduate training in ophthalmology, I had a chance to work in a really excellent institution, Kikuyu Eye Hospital, where we were able to offer, because of what we had, a really good clinical service. And I found colleagues who also really exemplified excellence in clinical ophthalmology. The research role grew with time after that. We had trained in the days when many times people kind of did things because they were afraid of what the consultant would say. So you did things because of what the consultant required. But one day I found a book called Evidence-Based Medicine that really connected with the way I think, because I found that there's a rational way of making decisions. There's a rational way of evaluating diagnostic tests and treatments, or questions I had about patients. So that began the journey of the research direction. And slowly I got opportunities to have some training in clinical epidemiology and systematic reviews. And so that began the growth in the research direction. The educator role, I think, came on formally a little later, although it had started earlier. Whenever you work as a doctor in most of our institutions, you have registrars who come on elective term, nursing students and students who are clinical officers who come to you because they would like to watch what you do. So the educator role became more formal because now after Kikuyu I came to the University of Nairobi. And that's when I think I really blossomed in that way, because I had now much more opportunity to interact with students. And I found I enjoyed it. You need to find what you're comfortable doing. For me, I found over time, of course, that these are things that I'm comfortable doing and that I really do enjoy. Some of that was reinforced by the feedback I got from people, from patients, from their relatives, from students. Number one, you need to be comfortable in your own skin. You need to know yourself and be comfortable with who you are. You're different from other people, and so you don't necessarily have to follow what somebody else is doing or compare yourself with somebody else. You need to be comfortable with what you're about. What is your purpose? As a clinician, I used to imagine that I would like to be an excellent clinician, and so usually we gauge a good doctor by the size of their practice. And so the bigger the practice, the more successful the doctor. You do make a lot of money, but it also means you have less time for other things, which for me are important. I have other sides of my life except just that one thing. You can make a living out of research, write proposals, funding proposals, and actually pay yourself for the amount of time that you're putting in. So there's no such thing as free research, really. I have other interests, and I generally have lived a life since high school where I did a lot of other things and tried to do them all fairly well. I gave them the effort they require. So work is just one part of it. I see a lot of interaction between those three. There's a lot of overlap in those three roles. If you're a good doctor and you're doing something well, before long, there will be students around wanting to see how do you do what you do. So I don't see any conflict between those three. They are very complementary. They are not independent events, and you can't say you're a doctor who is not interested in education or you're not interested in research. Those three are like a fruit salad.
Excellent. Excellent.
Professor Jefitha Karimurio. I'm the chairman, Department of Ophthalmology at the University of Nairobi. And I want to take this opportunity to thank OSK for inviting me to this annual Congress 2020 to discuss this topic on clinician, researcher, educator, our present and future roles in advancing the goals for eye health. And the way I'll divide my presentation is that I'll first discuss the clinician, researcher, educator, career interfaces, and then that will be followed with my personal experiences and training in advancing goals for eye health. And then we will look at the factors which are likely to define our future roles in advancing eye health. And then we will discuss the motivation and the choices of career path before we summarize. So ladies and gentlemen, the way I have planned it is that if we want to look at our present and future roles, it is also important to look at what has been there before so that it informs our present and then the future. That is why I have got that outline. Let's look at the clinician, researcher, educator interfaces. We are all clinicians, and that is why in this presentation, I've put clinician as green. And we have got an option of developing our career in research and also as educators, and somebody who is doing research and is also doing clinical work. We for the time being, we refer that as clinician researcher interface. Somebody who is doing clinical work and is also educating other professional, we call that clinician educator. Somebody who is a researcher and also conducting education is a researcher educator. And at the center is somebody who is both who is a clinician, researcher, and educator. At this point in time, as we discuss these interfaces, it is important to differentiate between a teacher and an educator because they are different. A teacher is somebody who helps others to learn new things. That is, they help people to acquire knowledge. An educator, on the other side, teaches, so it's a teacher, acquire knowledge, informs, and also inspires others into their profession. So an educator is more than a teacher. Now, let's look at my personal experiences, and I'll divide them into the phases I have gone through my career path. I'll start from 1990 to 1995. I graduated as an ophthalmologist in 1990, and I joined the Ministry of Health, where I worked in Machakos at Nyeri hospitals. And when I was there, I served as a zonal eye surgeon. I also served as a medical superintendent for Machakos Hospital in Nyeri. I also worked as the provincial medical officer for Central in 1994-95. What was the eye health situation then? We had very few eye care workers. It was not only eye health workers. We had also very few medical workers. And that is why you find that my role did not only include ophthalmology. I was also an administrator as well as a zonal eye surgeon. A zonal eye surgeon means I was in charge of several other eye units apart from the units where I was placed. For example, if we take the Machakos zone, Machakos covered Makueni, it covered Kitui, it covered Mwingi, it covered Kajiado, and also Loitoktok. When we talk of Nyeri, I was covering Nyeri district, the then Nyeri district, Kirinyaga district, Laikipia, and I was covering Nyandarua. It is because of the shortage. So we were playing very big roles. And because of these roles, I had to attend a course or courses, short courses on management, which helped me in administration in eye health and also administration in health as a zonal eye surgeon and the other roles I was playing in administration. In 1995, I realized that what I was doing was very broad, and I decided to resign from the Ministry of Health and join the University of Nairobi. So towards the end of 1995, I joined the University of Nairobi as a lecturer. And so now I entered the interface of clinician educator. So I was not only a clinician, I was a clinician and educator. Now the Ministry of Health wrote to the university because I had left a very senior management. I was in provincial administration as a provincial medical officer. And they said because I have come to the capital city, I should be the head of the eye care program in Kenya. By then, we used to call it Kenya Ophthalmic Program. So I was again appointed back into administration. I became the Kenya Ophthalmic Program Coordinator, a role I played up to the year 2001. I played for 7 years. Those who would like to know more about the Kenya Ophthalmic Program, because it's good to get this history, there is a publication which is in this presentation, which I presented in the year 2000 at the Journal of Community Eye Health, and one can look for that reference, or I can ask me and I can forward that, so that you know the history of where we came from. But in a nutshell, Kenya Ophthalmic Program was mainly a donor-funded program based at the Kenya Society for the Blind, and the ministry was just giving the human resources which was required. But basically, it was an NGO program. My personal experiences, the other phase which I would like to discuss is 1995, after I joined the University of Nairobi, and I was appointed the ophthalmic coordinator, up to 1999. What was the eye health situation? It had not changed much. We had very few eye health workers, and it was mainly, again, ophthalmologists and clinical officers. We used to say eye health was a program without a base because we didn't have community level workers. We didn't have the lower cadres. We only had clinicians. So it was a program without a base. So my role as a lecturer and coordinator was training all types of eye health workers, because now I was taking care of the entire eye health system in the country. So I had to lobby for more ophthalmologists because we didn't still have enough. I had to lobby for more clinical officers and clinical officer cataract surgeons. I had to lobby for community eye health workers. I had to lobby for ophthalmic nurses, and the list goes on. The ministry in 1996 agreed through our lobby to include primary eye care as an element of primary health care. PEC was integrated into PHC. And what that gave us is an opportunity to start training now community level workers. And that is when we started now training community eye health workers as part of PHC, or primary health care. And because of these added roles, I realized now in my career path, I also needed to add my skills. And I joined London in 1998, and I graduated in 1999 with community eye health, a Master of Science in Community Eye Health. And this is when I started now teaching research methods. I started teaching planning for eye care. I started teaching eye health promotion, and I started implementing these skills at the program level in the National Eye Health Program. By this time now, I had entered the center of the domains of the interfaces we are talking, because I was a clinician, I was an educator, and I was a researcher. So I was at the center of those interfaces I have shown you. Now let's go to the next phase, 1999 to 2012. Where was I and what were my roles? The eye health situation in Kenya, this was the era of Vision 2020 and GET 2020. Vision 2020, we all know Vision 2020 because it's the global plan for elimination of avoidable blindness. GET 2020 is a trachoma component of Vision 2020. It was global elimination of trachoma by the year 2020. And both were WHO programs running together. And I was in it. When I graduated in 1999 and I returned back to Kenya, I was appointed the IAPB, International Agency for Prevention of Blindness, co-chairman for the East African sub-region. The region was Africa, so I was in charge of overseeing implementation of Vision 2020 and GET 2020 in the Eastern African sub-region. And this was a big task because it gave me a lot of exposure. I facilitated and participated in Vision 2020 launches in Eastern Africa and other continents. So I traveled all over the world, the continents, for launches and discussions of Vision 2020. I was also the founder. As part of Vision 2020, we started now, I say the Kenya Ophthalmic Program was an NGO-based project, based at the Kenya Society for the Blind. Now, at the Ministry of Health, we lobbied and the ministry agreed we open a division of ophthalmic services at the Ministry of Health. Currently, that division is known as the Ophthalmic Services Unit, and we know the head of the Ophthalmic Service Unit is Dr. Gishangi, and this is one of the divisions which gave us a lot of leverage because we were included at the policy-making level of the Ministry of Health. At that time, because of Vision 2020, one of the most important things for Vision 2020 is human resource development. We started training ophthalmic nurses at the KMTC, and we started it in 2001. And now my career was again shifting from clinical side because I had a lot of administration and management responsibility. I was now coming to where now I'm based, where in those interfaces, I am more of an educator and researcher. I'm less of a clinician going to educator and researcher. And on top of that, as an advocate, it's not within the interfaces, but I have been an advocate for eye health in many aspects. Also, because of my experience now, I started being engaged in consultancies by the Ministry of Health, by NGOs, by the WHO, and also in many other capacities by country governments. For example, I started the eye care system in Eritrea and also the trachoma system in Eritrea. I'm the one who did the baseline, which established an eye care program. So I have gone to many countries because of my role in research and consultancies. Personal experiences from 2012 to 2020, the eye health situation is that now we are within the final phase of Vision 2020 and GET 2020. This is year 2020. And so it is an era where we see we have entered an era of subspecialization, globalization, and interprofessional collaboration. For example, if I take the cadre of ophthalmologists, most of the ophthalmologists who are graduating now, they want to be subspecialists. Are you a retina specialist? Are you a pediatric specialist? And the list goes on. In terms of globalization, we have realized that East Africa, for example, an ophthalmologist who graduates in Kenya, within the East African community, you can very soon you'll be able to work in Tanzania, Uganda, and other countries. So it means that you can work with one qualification, you are allowed to move from one country to the other. We have seen big eye units in Kenya now, they are also recruiting from outside the African continent. They get specialists from India, they will get them from UK and US and other places. So we are globalizing, and that is going to change the roles we play in eye health. And now there is the other aspect of interprofessional collaboration. Because of subspecialization and we are within a very limited career area, we need to collaborate with other people or other professionals to be able to deliver or to our patients. For example, I'll give diabetic retinopathy. You'll find that as eye health workers, we need to work with diabetologists, nutritionists, community workers, technicians who are taking retina photos and so on. So we work with many type of professionals. So for me to get an edge in that era of subspecialization, I went to Melbourne, and in 2012, I graduated with a PhD in ophthalmology. And that PhD including development of innovative trachoma survey methods. If you Google my name and the PhD, you'll download the PhD thesis and you'll be able to see what I'm talking about. But now, when I did that, I was able to lobby for review of global trachoma policies regarding trachoma mapping and implementation of trachoma interventions, and also survey methods. If you look at the survey methods which are being used now, you'll find that what they are using, there is a lot of contribution from my PhD. Because of graduating with a PhD and also the experience, now I entered the phase of technical advisor, and I am an advisor to the Ministry of Health, where I am among the panel of experts for elimination and certification of NTDs, neglected tropical diseases in Kenya, especially because of my experience in trachoma. I am also in eye health because I am also reading, for example, diabetic retinopathy research. I am also the chair of the research committee for the interagency coordinating committee for eye health at the Ministry of Health. At the region, I am with COEXA. We have got the EXA Eye Health Committee, and I am a member. At the global level, I am an advisor to the ASCEND global program. ASCEND is the Accelerating Sustainable Control and Elimination of NTD. It's a global program. I'm an advisor. So in eye care or eye health, I am a team leader, definitely in trachoma, which is both eye care and NTD. And I'm also spearheading the National Diabetic Retinopathy Research. So I am now more of an educator and researcher at the moment. Now, if we look at all what I have presented about my personal experiences, I have summarized it in this table, but what I want us to concentrate on is the last column, because I have got the year, the milestones I gained, the roles which I played in advancing eye health goals. But you see, it required training in clinical work, management, teaching, research, advocacy, project planning, management, collaboration. It required faith, it required courage, and all this. And so you can look at that and see it takes a lot of effort to be able to progress in career through these interfaces. What is likely to define our future? Because for the young ophthalmologist, you ask now, how does the future looks like? Because our role will depend on the situation which is current. What we address is determined by what are the needs of our eye health program. One is that we need a lot of advocacy for eye health to be relevant, to continue to be relevant. You have seen when COVID-19 started, eye health units were converted into isolation center. So for us to continue to be relevant and be allocated budget, we need a lot of advocacy, and that is why we need to have an edge. There is also the growing need for scientific evidence. If you are practicing as a clinician, we are talking of clinical or evidence-based practice. If you are planning for eye health, you need evidence. If you are doing health promotion, you also need evidence. So there is also what we have talked about interprofessional collaboration, and I have given the issue of diabetic retinopathy. There is also increasing competition because we have got many cadres now, subspecialization, globalization, which means you need a competitive edge. So you need to look at the domain where you are best positioned and where you perform best. We have got more educated patients, and they read what they call Dr. Google, and they can take legal action. So you cannot say you do not know the new treatment method and this if a patient sues you. So you need to keep up to date. There is also the insurance-driven practice and the very high cost of eye health care. Now, the patients are over-doctored, patients are being treated, and we are using very sophisticated diagnostic technology, surgical communication. Even notes now, you need electronic notes. And because of all this, you need to put yourself in the domain which makes you function best with the prevailing situation. Motivation and choice of a career path. And what I would say is we are clinicians with a lot of opportunities to advance through these careers I have talked about. Choose what motivates you. Some people think it is money. No, it's not always money. And you find some people will go into any donor-funded project. As long as there is money, they choose it without motivation. I would advise against that. Some would say, I'm as available as oxygen. If you have got money, let's go and do this. So others would like to look for honor and fame. You can be a famous doctor, a teacher, or a researcher. So you can choose any domain. So it is your motivation. But remember that you should always allow room for flexibility, because motivation and eye health goals will change from time to time. You should also have hard work and perseverance, whichever the career path you choose, because you must develop yourself. So in summary, a clinician researcher educator career path offers many opportunities to influence and to advance eye health goals. Choose the path which motivates you. My career path, which I have given as an example, had many twists and turns, and that is why I'm advising that you be flexible and adaptable to change. It takes faith, courage, hard work, and determination to succeed. And I wish you the best. Soldier on, and thank you very much for listening to me.